for standing up for children. Have done the other one.
A contribution for 200,000.
Alikuwa nalala akasema.
Yes, Doctor, as we had discussed earlier on during the week, we had requested you to help us discuss the common causes of miscarriage, how we can avoid them, and what we need to know in case someone is experiencing it, how do they go about it, the healing process and all that.
I'm just typing this. I had sent out a live for this session. Unfortunately, we had a bit of a miscommunication, so I'm just sending the Zoom link to others who may have wanted to join. I hope that's okay with everyone.
Yes, that's okay.
Okay. Yeah, so talking about miscarriages. Miscarriages sadly happen to the best of us. And 1 in every 4 women, or 4 to 8 women, will tell you that they've had a miscarriage in their past. And most of them, in fact, 60% of the time, we say that there's nothing that they could have done different. Miscarriages tend to happen because of some factors, most of them how the union of the sperm and the egg happened. So sometimes when the union is happening, you end up having the fusion not happening in the right manner. So when that fusion does not occur correctly, then the body does what is called a selection. So it looks at the baby, or let me say the zygote that has been produced. And when they find that the zygote is not suitable or compatible with life, then a miscarriage will happen. Call it a spontaneous miscarriage will happen. So for some of the miscarriages that we had, they have other factors that are preventable. For example, patients who have diabetes, patients who are known to be hypertensive, or have thyroid disease, or have autoimmune disorders, then those particular ones, then there are things we can do prior to the pregnancy, and we require to see them before the pregnancy so that we can kind of control the disease process so that the pregnancy is able to be taken to term. So we have types of miscarriages. We have the most common ones happening within the first trimester. And when it's a one-off, we have like the blighted ovum, or you'll be told the pregnancy had no, that they could not find the egg inside the pregnancy. So that particular one can happen, and it is not likely to recur, because, as I've said, it's one of those where the genetics just didn't match in that particular pregnancy. That doesn't mean you end up in a divorce, no. It's just a mismatch in that particular gestation. But then we have those where we have recurrent losses. For example, you've miscarried the first, second, third, fourth pregnancy, especially in the first trimester. Then we start thinking, is there anything that is attacking the fetus that is being born or that has been conceived? So that kind of loss will probably be a miscarriage. So a miscarriage means that it's a pregnancy that started and then it stopped. So you'll find that you do a 7-week scan and then there was a heartbeat, and then you come back and do another scan and there's no heartbeat. So unfortunately for that particular one, it is the likelihood that sometimes it can recur, but usually it is associated with a problem that we'll find prenatally. Yeah. If we can't find it by screening for the diseases that we find commonly, we'll screen your blood for an autoimmune disorder that may be silent, or we will also carry out even genetic typing, where we take the blood of the mom and the blood of the dad, and then we take it through genetic screening, which may be slightly expensive, but find out if there's that particular kind of mismatch. And then we advise on how to go about it so that we can have a safe pregnancy. That said, we have those ones that just come out. You find it in between the process of coming out. So you're okay, and then now you just start bleeding. In those cases, we advise that if there was no earlier scan, it's difficult to have known. Yeah, so it's difficult to know what could have been the problem prior. So for that reason, we advise mothers, once you know you're pregnant, especially the history of a miscarriage, please go to your gynecologist early, and then we can do a scan just to ascertain if the baby is doing well or not. And if any sequelae happens, God forbid, then we know how to manage it. We have medication that we give to moms who have had previous losses based on what we find when we screen. So if ever you find that you've had a pregnancy loss, then please go to your gynecologist, and then we will screen and see if there's a problem. Usually we say 2 losses or more, but in the event you've had the first loss, and we all know the pain, we may not all know the pain of losing a pregnancy, but it is quite painful. Even in the first loss, you can be able to, Belinda, let me just request that you remain the host for now, so that you can do these things of meeting people. Don't know how to do it or where to do it from. And how to make you the host again. Oh, I've seen the button. Okay. All right. Yeah, so technology is something that I'm learning every day, and I'm excited to learn it. Anyway, so whenever we find that we are having recurrent losses, or even just that one loss, go to your doctor after 2 months. 2 months after the process, they'll do some blood tests, some on your hormones, some on your immunity factors, some to check whether there's autoimmunity, and also like infections that may not have been known prior. And then with this, we're able to figure out if there's a problem. So that's the first trimester kind of loss. We have the second trimester losses, where you were okay, you got to 14, 15, 16 weeks, and the baby just comes out, okay? In that case, more often than not, it could be that the cervix itself is not strong enough to hold a pregnancy. This is the saddest because you actually expel a baby, but it's also the easiest to treat, because it means when you get to the second trimester, before we get there about 11 to 12 weeks, we can put a stitch to hold the cervix and try and give it more strength externally to hold pregnancies to term, okay? So we have different types of stitches. The women who still get a miscarriage after a stitch, we put another stitch that is more permanent, which will mean we may have a cesarean section afterwards, but it's put way up, rather behind the bladder, close to the internal os of the cervix, which just means the inner gate of the cervix. And when we put that stitch, then a pregnancy is able to be held term. Yeah, so that's another kind of pregnancy loss. We also have one in which we have a third trimester loss, and most often or not, we will call that premature labor, where either due to chronic infections or the cervix was triggered or trauma, you fell down, someone hit you, God forbid, because of all that, then you end up with a pregnancy loss. Yeah. So we actually, if it's beyond 28 weeks, we will count this as a live, or not a live pregnancy, but a near-term pregnancy or a preterm loss. Yeah. So in that case, if you find you're having that recurrently, then we need to screen and see, do you have infections that are lining the vaginal tract that we don't know about before we check? So those kind of infections can cause the cervix to be thinner or trigger labor, okay? For this reason, if you find that you're having a discharge in pregnancy, a chronic discharge in pregnancy, kindly, please go to hospital. There's nothing like a normal discharge in pregnancy unless we have ascertained that there's no other cause for it, because that kind of chronic irritation can cause the cervix to open up and give you preterm or premature labor. Okay, so the word of caution there is, if at all you find that you're having a chronic discharge, please go to hospital, let us treat it. Let us treat your partner as well, so that you don't keep getting reinfected. Okay, so that's on preterm losses. The other thing that you can do is just ensure, if it's happened before, work closely with your doctor, try and avoid a similar situation. We give you progesterone all through the pregnancy, which can be expensive because of the cost of progesterone, but it's also helpful for the pregnancy. We also give you blood thinners and other medications just to protect the pregnancy, multivitamins and water. On your end, as someone who has suffered a miscarriage and then now is pregnant again, what you can do is really, I'd say the first point is trust God. We call them rainbow babies because God saw your pain and gave you another child. But you need to be diligent with your antenatal care. Okay. We need to make sure you've been seen in the first, second, third trimester. There are screenings that we do, screening for hypertension, screening for diabetes, that we need to also ensure that you take seriously and are able to go through those particular tests with your doctor. If you have history of recurrent losses or Down syndrome in any of your children, there's a test we do, a screening test we do at 12 weeks and another one at 18 weeks, just to confirm if the likelihood of this particular pregnancy having Down syndrome is common. So that's another thing that you can do on your beat. But you need really just patience and a calm time if you can. There are seasons we may tell you don't go to work at all. There are seasons will tell you, okay, you can work, but you need to be off strenuous exercises, sometimes even off sexual activity with your partner, with your husband. And the grace to adhere to it is what we really need from you. And also an understanding partner. So I know that's not much that you can control in that line, but having your partner with you during the pregnancy clinics also helps, because he's present when these decisions are made, and then he's able to understand and walk with you through that particular journey. But we do have ways in which we can prevent recurrent losses, and we have ways that we can treat so that we help you carry the baby to term. Okay, so I think that's sort of like an overview of what it is and what you can do. My internet is unstable. Okay, I think I'm back. Yes, so that's an overview of what you think you can do in the subsequent pregnancy. But when a loss happens today, please remember to treat the loss as any other death. Okay, and I'll use that name intentionally because you need to take your time to grieve the pregnancy. You need to take your time to and with your husband really, or with your partner, walk through the pain, talk about this is what I think happened, and just go through that together. Because if you don't walk through it together, it can actually lead to depression, it can lead to loss of marriages. We have seen marriages and relationships that have broken down because of lack of communication during the grieving process. Remember, everyone grieves differently, and if you're a woman of faith, then please pray through that process. Pray together through that process, because it has the potential of really breaking you, and it does break you. But the point is to not allow yourself to go under. Yeah. So really just remain strong in God, remain strong in the fact that your life to see yet another pregnancy come to pass, and that your womb has not been forgotten. Doesn't mean you can't get pregnant, and most women actually have a struggle in getting pregnant. Your struggle is maintaining the pregnancy, and that is something we can work together in. So please allow the grieving process to happen. Remember, everyone experiences pain differently. Do not go through it alone. If you have people you can open up to, open up and say, this is what happened, so that you're not going through like loss alone. And that also helps you to kind of get over the initial sad phases, the we call them the 5 steps: the denial, then the through acceptance, and then all through the other 3 processes. Yeah. So if at all a loss has happened, remember you are both parents. So if you feel like your partner is not understanding you at that time, remember he is also going through his own type of grief. So perhaps you can bring in a minister of the word, or you can bring in someone that you both can trust, or even your gynecologist, to talk you both through the process so that you understand, in your case, what exactly happened and how can we mitigate it later. And then now, of course, remember to go for your clinic afterwards so that we make sure we find out what could have gone wrong and how to prevent it. I think that's the most crucial thing I can say at the moment, because most women just go on to the next. There's the advice we say that if you've gone through a loss, then if you can get pregnant really, really quickly, but remember to give your uterus a break of at least a cycle or 2, because that cycle or 2 allows your body to heal, go back to a pre-pregnancy state, and then now is able to carry another pregnancy. Okay, so I think that's what I had to say as an overview. I'm seeing a question from Esther. See, you've raised your hand. Perhaps you can just ask your question.
Doctor, thank you so much. So you've said that after a miscarriage, someone should wait for at least 2 cycles to conceive again. What happens if they conceive before then?
There is no problem if you conceive before the 2-month cycle. What will happen is if we had done the test prior, well and good, then we'll know what to do. But if we hadn't, then we'll hit you with everything we have. We'll give you all the medications and try and treat everything just to kind of protect you. But if at all the problem was, for example, an autoimmune disease, that requires daily injections sometimes. So such kind of a very acute solution we will not give you, because we had not found it. So basically that is it. But other than that, you remain really fertile, especially after any pregnancy or miscarriage, you're very fertile. So it's quite possible to conceive immediately afterwards. Just that it denies your body healing time, and it denies a chance to find out what really could have gone wrong. But if it does happen, don't fret. Just go back to your gynae and tell them this is what has happened, and they'll still work with you.
All right, thank you so much. Ladies, you can be sending in your questions in the chat and I'll read them. And the doctor will be here to answer all our questions. Another question, there are some people who are going through unexplained infertility. Like doctors do all the tests and they can't find any possible cause of the infertility, but then they're not able to conceive. What could be the cause of that?
Infertility. It's hard to answer about infertility without having screened you for infertility issues. First of all, we need to remember that infertility is something that we look at after 1 year of regular coitus without being successful, which means in 1 year of regular coitus, and regular we mean 3 to 4 times a week, you have tried to conceive and not been successful. So most people fret at about the 4th or 5th month, especially of a new relationship, new marriage. And then they come to the clinic and I haven't conceived, what's going on? You need to understand that in every cycle, only about 10% conceive normally. So which means in every month where you have coitus with your partner, at the beginning of the ovulation window, dad is okay, his sperm is fine, mom is okay, his sperm is fine. There's only about 10% people, 10% of the population, or 1 out of 10 women who are going to conceive. But if you give it the 1 year, then ideally 10 out of the 10 women will have conceived. That's why we give it that duration of time. Okay. Usually the factors that we check when we're looking at infertility, we look at the male partner because they cause 35 to 40% of the issue. And then we have the female partner, also has another 40% of the issue. Or we have combined factors where mom is not very fertile, dad is not very fertile, but we've come together. So that's called a combined infertility concern, in which case we treat mom and dad separately. Okay. That is to mean whenever we're looking at infertility, we're not looking at one person, we're looking at mom and dad, or we're looking at the husband and the wife. And when we're looking at the female, we're looking at how is the entire tract working. Yeah. So we start looking at the brain, at the hormones being released by the brain optimal. Then we go to the ovary. Is the ovary responding to the hormones being produced by the brain? Then we look at the fallopian tube. Is the tube patent? Is it able to pick up the egg from the ovary and bring it to the uterus? Then we look at the uterus itself. Have you had any prior issues in the uterus? For example, have you had a prior miscarriage and was washed out, or a termination and washed out? Was it done too much so that now it has scarring on the sides? Was something left? Sometimes the small particulates that are left inside the uterus, if the cleaning is not done well, and then or bony spicules that are left inside the uterus, and then that causes you to not conceive. In effect, it works like a coil of sorts. So is the uterus able to do that? If the uterus is able to carry a pregnancy, then is the cervix able to carry a pregnancy? Is the vagina patent? Is the hymen actually broken? So we look at all these issues in the female. But is everything working on that side? When we go to the dad, we look at the sperm. Is there sperm being produced? Is the sperm that is being produced adequate in terms of number? We need about 40 million sperm to get one baby. But men in general produce about 150 million. So is this sperm adequate in terms of number? Is it moving in the right direction? Is it empty? Because sometimes you have ejaculate that has no sperm because of a blockade up in the tract, maybe from trauma, from football, from cycling, or wherever. So, or our previous mumps, for example, disease. So we check all these things and then we're able to to see and work with a urologist to help the male partner. Okay. And then now we look at both factors, we give both supplements and see what to do. Okay. Even if we find one sperm, just one, we're still able to help the partners conceive through using now things like assisted reproductive technology, such as IVF, or things we call ICSI. So there are things that we do to help the partners still get a baby. If we find that the tract is a problem, for example, the tube has a problem, it was blocked due to prior infection, then we cut up the tubes and use IVF, for example. If we're not able to find the issue altogether, and we still are finding that this couple is not conceiving, then we can go the ART way. We take an egg, we take a sperm, we try and check it in a tube, can we get a baby? Then now we reimplant that. So in other words, there are many other things we can do during the infertility process to see. And sometimes you just need to balance hormones. People who have thyroid disease may be unable to conceive because the block is coming from the brain. Sometimes you may have a tumor in the brain that is producing too much prolactin, the hormone of breastfeeding, and that will also prevent you from getting pregnant. So really, you just need to work with your doctor to know what the problem is. Yeah.
All right, thank you so much. So from the chat, someone is asking, how soon does or can one conceive after delivery? What godly family planning options are there that can be considered?
Godly. I don't know if it's a family planning method godly, but there are women who conceive almost immediately after, especially if you're not breastfeeding exclusively. And by exclusively, I mean breastfeeding every time the baby cries for milk, every 3 to 4 hours, and every single day. Yeah. So those particular women may end up having their periods rather early. We have seen women who, after 4 to 6 weeks, they're back to the ovulatory cycle and can get pregnant again, which is why we really insist upon the 6th week to go back and do your family planning visit. Family planning has a hormonal part. We have hormonal options of contraceptive. We have non-hormonal types such as the coil. And all these methods are liable or are usable by women to be able to get a baby. None of them kills an egg, if that is what you mean by godly. So from the medical perspective, we have all these options, although some we may actually decide to close the tube if the mom feels like they're done completely with getting a baby. And that's tubes for the male and the female. Just a minute.
Thank you so much. Doctor, are you still there?
She asked for a minute.
Okay. Keep sending in your questions on the chat and we are going to handle them. If time is not enough, we are going to continue with the chat on the group and maybe have another session with the doctor in future.
Hi. Yes, so we are mothers even as we are doctors. So now that calm. I think we can continue.
Thank you so much, Doctor. So another question. You mentioned something to do with chronic discharge leading to miscarriage in the second trimester. Can you shed more light about it?
Chronic discharge will actually give you a preterm labor. So that would be in the third trimester. But what usually happens is, okay, what usually happens is that the discharge affects the cervix. Okay, so you have say hi to everyone. Okay. Yeah, so what happens is that you have this discharge going in from the vagina all the way to the tract and the cervix. So when it affects the cervix, the cervix starts to get triggered to, it's trying to fight off this infection. We end up with what we call a chronic cervix infection. And you know, with an infection, the inflammatory markers or the body will produce cells to try and fight off that infection. So those bodies or those responses from the body to try fight off this infection are actually what will trigger labor. So what we find is, especially if you're having a chronic candid infection or that yellow, grayish, brownish discharge that just is not going away, we need to treat it earlier so that these inflammatory markers are not triggered. And then if they're not triggered, then the cervix remains with its integrity. And remember, the cervix is a gate to the uterus. So if the cervix is compromised, in effect, it's having a broken gate at the front of your house. So of course, it's going to let things in or out. In this case, it lets out the baby and lets in infections, sometimes even to the baby. So that's the best way I can explain it.
Thank you so much. Another question. Is too much bleeding during menstruation as a young girl, can it lead to infertility? And is there anything that can be done?
Too much bleeding, we need to quantify what is this too much bleeding. In a normal cycle, we have a loss of about 20 to 80 ml of blood, which means about 3 to 4 pad changes, which may happen between 5 to 7 days or 3 to 7 days. Anything that is counted as normal. So you find you're changing 6, 7 pads with clots and such things, then that is not considered normal, in which case we really need to find out why. Yeah. In young girls, the hormones are not yet stabilized. There are ways of stabilizing them using hormones, but we tend to just observe and see. No, it's not a factor that can give you infertility unless the problem is endometritis or endometriosis, which would be accompanied with a lot of pain in the abdomen, sometimes in the rectus, in the rectum. You're trying, and during your periods, even poop becomes a problem because it's bloody or really painful. If you have such symptoms, then you should go to your gyna to have it resolved. Otherwise, it's a difficult question to answer if we have not examined too. But yes, there are ways of reducing the blood flow.
Thank you so much. Someone is asking, what might cause one not to have their periods ever, now a 20-year-old?
If
a 20-year-old has never got their periods.
Okay, if they've never come, then that is a problem that needs to be addressed. above 16 years of age, we say that at least a girl should have gotten their menstrual cycle, even if it's not regular. Yeah. Yeah. So even if it's not regular, they needed to have gotten their menstrual cycle. So there are things we need to check from again, we'll follow the same track: the brain, the ovary, the uterus, and see if there's patency. So we need to see in all stages what could the problem be. They could be having an adrenal hormone that is overstimulated, that's blocking the pathway, or hormones from the brain that are blocking the pathway, or something genetic or congenital, like a malformation that had not been observed prior. So advice is to go to your doctor, have it addressed, have it screened, and then now we find this problem, and then now we can get the solution, case by case basis.
All right, thank you so much. Is it true that some family planning methods are abortive in nature? That is, make the uterus unbearable for an embryo to attach?
Yes, it is. The coil, particularly, that is one of the ways it works. Usually it would prevent the uterus, the sperms from going up the uterus, or the egg being able to come down into the uterus as well. Or if at all conception has happened, then irritating, the lining is too irritating for the egg to implant, the embryo or the zygote to be able to implant. Yes, there are methods that are irritative in that nature. Most of the others just make the cervix very, very, very thick, and the lining very, very thick, so that oh, I'm getting fainter. It's saying my connection is unstable. Sorry. Yeah, so most of the hormonal methods just make the cervix, the gate very thick, so that the sperm is unable to go up. But something that we put inside, such as the non-hormonal family planning, yeah, so such as the non-hormonal family planning are irritative in nature, and that's how they've been designed to work.
Okay, should a lady get worried if she gets cramps after inserting an IUD?
Pardon?
Should a lady get worried if she gets cramps after inserting an IUD?
No. The first thing that happens during when you do coil, sorry for that. The first thing that happens is when you put a coil, it irritates the uterus itself. So because of that irritation, you get cramps and increased blood flow. So you may have the first periods being very heavy, you may have a bit of spotting, and then and cramps. So that shouldn't concern you. It's part of the normal handling, the body handling this new thing that you've inserted inside it. But after 6 months or so of having the coil, it usually relaxes, so that there's no much pain and there's no much what is it called, bleeding. But I have done a video on that, so you can just check it on the live and you'll find.
Thank you so much. Advice to a mom who just found out she's pregnant with a 9-month-old baby.
So advice to a mom who has found out she's pregnant at 9 months. Does that mean they were getting their periods and then they stopped, or how was that?
I think they mean where you find your little one is 9 months and then you're also pregnant.
There are cases in which you find mothers have 2 uteri. So when you have two uteri, it is possible for you to get periods for 9 months and still be pregnant. Yeah, the baby tends to be smaller, but it has happened. It's rare, but it can happen. The advice would be really just to start your clinics. It's rather late, but start your clinics. And then after you start your clinics, they'll do the regular screening checks. Most of them can deliver normally, but you need to really just wrap your head around it. It's more emotional support now than it is a body support. I don't know how to say it. It's like we're supporting you to adjust to 9 months of having grown a baby without the knowledge of it. So family needs to be very supportive. Your doctor needs to be very supportive, but it has happened prior, and the deliveries tend to be okay. If at all there's a concern when we're doing the scans and what have you, a cesarean delivery may be given as an option, but it has happened prior. There are also women who maybe have one uterus but have history of irregular periods, and therefore thought that it was just an irregular period, that maybe a window without periods, which is normal for them. So they should not be victimized for not having known they were pregnant, especially if they're bigger bodied in terms of body wise. So we've also seen that before. And again, just acceptance is what we need. And we get the baby, and you'll be awesome moms, so don't worry.
Thank you. I've been there. So it's possible and it's manageable.
Yes.
Someone is saying, I have increasing vaginal discharge in my 3rd trimester, which seems normal, whitish. Now 33 weeks and 5 days. Should I be worried? Which test is recommended?
My advice would be to have a swab taken that will check if it's an infection or leukorrhea. Leukorrhea is a normal discharge of pregnancy. If at all it's an infection, then we definitely need to treat it, but more likely than not, it is possibly a fungal infection that just needs to be treated and it will go away. Also, drink a lot of yogurt, drink a lot of natural probiotics, have both partners treated, because both can give the same issue. Like you may be treating mom, and then when you meet with your husband, he reinfects you with what you had before because we had not treated him before that at the same time. So basically, that's another way to look at it.
Right. Thank you so much, Doctor, for this time. I'm not seeing any more questions on the chat. In case you have any, I'm seeing one here. Are there any risks with being pregnant 9 months postpartum?
Yes. Mostly the risk is to both your children, that if your newborn may not have oh, you guys, sorry about that. So mostly the risk is to your children, that the young one was still breastfeeding and we may need to stop them from breastfeeding. And the older one, your older one may still be breastfeeding, and then the young one in the womb needs more vitamins, more medication, really, just to grow and survive, because your body had not bounced back from the pregnancy and delivery period. But when we do find you pregnant 9 months postpartum, then we just sometimes we'll ask you to stop breastfeeding, especially if you have bleeding irregularities in the first trimester. If not, some books say we can just continue with breastfeeding, but we give you supplements to support both the fetus and the baby. We also need to make sure that you're not carrying heavy weights other than the baby. But remember, by this time, your baby is almost 10, 11 kgs. So that's heavier than the recommended 8 kgs of pregnancy. So you may need a bit more support in that. If you had a cesarean section, then it means we'll have another cesarean section quite at the end of that pregnancy because the window had been short. But otherwise, it's okay. It's something that can be managed. It's a high-risk pregnancy, but that is manageable with your doctor. What's wrong?
Thank you so much, Doctor. I see our time is almost up. Ladies, let's appreciate our doctor before we start our closing prayer. And let me know if you need another session with her and what topics you'd like her to talk about.
Thank you so much, Dr. Thank you, thank you, thank you. Thank you for the knowledge. We really appreciate. We also appreciate seeing you working together with the children. Thank you.
Yes, thank you so much, Doctor. We truly appreciate your time. We look forward to having more sessions with you. And thank you for availing yourself to answer our questions in the group and here on this call. May God bless you and your family. You have a very healthy son over there. May God bless you so much.
Thank you. Thank you so much. Be blessed.
Amen. Pastor, any announcement before the closing prayer?
No announcement, but I want to appreciate every mother of nation. Let's keep doing this. Let's keep on protecting that which God has handed into our hands. Let's keep on praying for them. Let's be available to learn. We are going to talk to Daktari to be our official doctor. Wow. Thank you so much. Thank you for being here. Yeah, and thank you so much, Minister Belinda, for loving us. We all, and I appreciate you. Let's keep doing this. Amen.
All right. Let's say a closing prayer. My baby girl